Hello. Thank you so much for joining us for NAMI Maryland's 40th annual conference. My name is JB Moore, and I am a volunteer with NAMI Maryland. I will be your moderator for the session today. This workshop session is Culture, Context, and Early Psychosis Identification and Intervention for Underserved Youth and Families, presented by Pamela Rakshan Ruakhtar and Tiffany Beeson from the University of Maryland, Baltimore County, and Gloria Reeves from the University of Maryland. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website. This presentation will provide a brief overview of psychosis spectrum symptoms and highlight advances in early identification and intervention services. We will share unique considerations, challenges, and adaptations to assessment and treatment strategies for providers working with youth and families from underserved communities experiencing mental illness with psychosis. Information about the Maryland Early Intervention Program, EIP, including the components of EIP, services provided to the community, and how to connect with EIP will be reviewed. The talk will conclude with an interactive discussion, soliciting attendee feedback and perspective on this topic. If this is not the workshop you meant to attend, please click the back button on your browser or click the sessions button on the left-hand side of your screen to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them to the Q&A on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenters after their presentation has concluded. We are pleased to offer closed captioning for this year's conference. Captioning is only available for attendees using a desktop. To enable captioning, please click on the double capital C's icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video displays will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, please post them to our chat and our technical assistant will address them accordingly. I'd now like to welcome our presenters for today's workshop, Pamela Rakshan Ruakhtar, Tiffany Beeson, and Gloria Reeves. Thank you so much for joining us today.
Thank you so much for that very warm welcome and perfect pronunciation of my name. We're extremely thrilled to be here with you all, and we can't wait to share what we have to talk about today. Okay, so I will get started, and we're going to be, as the wonderful JB Moore just introduced, we're going to be talking about culture, context, and early psychosis identification and intervention, particularly thinking about how we can do this best for underserved youth and families. So I have to thank my wonderful co-presenters for not only helping me to develop these slides, but also for doing the work that I will be sharing with you all today. I also wanted to thank our broader collaboration teams at the University of Maryland School of Medicine, University of Maryland, Baltimore County, Morgan State University, and particularly wanted to thank the youth and families that we work with, both in our clinical services programs and in research. We for sure could not do anything that we do without all of your partnership. So I'm going to first get started here with our agenda. I will briefly review psychosis, early intervention and identification, talk about how we might think of special considerations and adapting these kinds of things for underserved or marginalized youth and families, make some brief summaries, and hopefully we will have a robust interactive discussion and question and answer section. And one thing that I want to share is that I can only scratch the surface on all of these topics. So I hope that we will get to meet again, and I will be sharing some resources, hopefully throughout the presentation for you to be able to have somewhat of a deeper dive of this content area. And the objectives of today's training and presentation is to first just learn a bit about psychosis, and particularly how we are kind of newly understanding psychosis as a spectrum, and thinking about how early identification and intervention can be really helpful for the youth and families having these kinds of concerns. I'll share briefly about the Maryland Early Intervention Program and all the great work we do, and again, talk about how we can adapt these kinds of practices, tools, and resources for serving youth and families from diverse communities. Okay, so I'm going to get started giving a brief overview of what psychosis is. So psychosis includes a few different types of symptoms. The first symptom that we most commonly think of when we think of psychotic disorders are positive symptoms. And positive symptoms aren't positive symptoms good. They're what we would describe as behavioral excesses, or things that are added on for folks experiencing psychosis that are not there for typically developing folks. One of the primary types of positive symptoms are delusions, which are defined as false and fixed beliefs. So some examples of types of delusions that people experience could be thinking that people are talking about them, thinking that someone might be following them, thinking that people are possibly plotting against me, or even thinking that aliens are sending messages through the TV. And as you can see, there's quite a range of different kinds of thoughts or experiences that might qualify as a delusion, some of which might be things that could possibly be happening or that could commonly happen for folks, to things that are not possible or kind of outside the realm of reality. Hallucinations are the other type of positive symptoms, and these are perceptual or sensory abnormalities. You can have hallucinations across all different types of the sensory system, so auditory hallucinations or hearing things, visual hallucinations, seeing things, or different kinds of visual experiences like color changing or seeing things in a different way. Olfactory hallucinations or smelling things, gustatory taste, or tactile hallucinations. And the most commonly reported type of hallucination is auditory hallucinations or hearing voices. Negative symptoms are another type of psychosis symptom, and these are things that are taken away or things that are deficits for folks who are experiencing psychosis as compared to their typically developing peers. So negative symptoms across the board are typically associated with a decrease or a loss in normal functioning. Some examples of these negative symptoms include social withdrawal, not being as interested or engaged in social relationships, decreased motivation, really struggling to do things that folks typically would do, difficulty feeling pleasure or enjoying hobbies or fun things that folks used to enjoy. And although a lot of times we focus on the positive symptoms that I described earlier in psychosis, it's really the negative symptoms that clients often report as being the most interfering with their goals, most distressing. And often these types of symptoms represent the most difficult symptoms within psychosis spectrum disorders to treat. And lastly, we have disorganized symptoms, which is a third type of psychosis symptom. And these are things that are behaviors or symptoms that just don't quite fit the situation, or they don't really make sense in the context in which they're occurring. So the first type of disorganized symptom that I'll share with you all is disorganized speech. So this is speech that can be difficult to follow for a few different reasons. So this might mean that folks are slipping off topic or going off track, going on a tangent that kind of deviates from the point they were trying to make. Having speech that doesn't really quite make sense to others, or speech that seems unrelated to a conversation that folks were having. So maybe someone asked about someone's day and they're sharing something totally unrelated, and the person asking the question is kind of like, how did you get there? So this maybe makes sense to the person speaking, but in the context of the conversation doesn't quite seem to fit. Disorganized behavior is the second type of disorganized symptom. These are behaviors that don't fit, behaviors that represent declines in goal-directed behaviors or daily living, and also just catatonic behavior, or kind of a withdrawal or decline in behaviors, generally speaking. So these can include things like dressing in an unusual manner, wearing a really heavy coat when it's quite warm outside, having an emotional response that doesn't quite fit what's going on. So maybe telling a story that's quite sad or upsetting, but kind of smiling or laughing when describing it. So the way the person is responding for their own kind of normal baseline or for their own cultural context doesn't fit what they're talking about. It can represent difficulty just with daily living activities. So the things that folks need to do or want to do in life or that they used to be able to do, there's a sharp decline in their ability to cope with those types of tasks, or just not responding or reacting to the environment. So psychosis is not a diagnosis in and of itself that we would give to folks in a mental health setting, but it represents a syndrome or a collection of symptoms that seem to hang together that we're not quite sure what the cause of these kinds of experiences are. So the different types of symptoms I just described sometimes hang together and can hang together in really different ways across different people. So one thing that we often say about psychosis is that it's really heterogeneous or really unique from person to person. That being said, there are a number of different disorders that folks might get when seeking mental health treatment that reflect part of the umbrella of psychosis spectrum disorders, which unfortunately are not showing up in my slides, but which include things like schizophrenia, or one of the hallmark diagnoses of psychosis, but also things like bipolar with psychotic features, major depressive disorder with psychosis, or substance-induced psychosis. So psychosis can look a lot of different ways when we're thinking of different psychiatric diagnoses that folks can receive. And traditional kind of diagnostic thinking in the field used to represent a binary or a category. Either one had a diagnosis of psychosis or they didn't. But we're increasingly moving away from that thinking, both in terms of the research field and also clinical service field as well, to think more of psychosis as something that exists on a spectrum, ranging from kind of the least amount of psychosis to the most. And when we look at the population, we see that most folks tend to kind of exist or lay on that less severe end of the spectrum. But that being said, most folks do experience in some form or fashion some kind of psychosis at a non-clinically significant or kind of low level throughout some point in their life. And this can include things like if you're like me and you have a lot of laundry piling up potentially in your house and you're rushing to get out and get ready for your day, you might see a big pile of laundry out of the corner of your eye and think it's an animal or something else, and then look back and say, oh, that's just my laundry. I should do that later today. Or you're at a crowded place, you might think your name is being called, and you turn around and no one called to you. So despite the fact that not a lot of folks have a psychotic spectrum disorder at a clinically significant level, it's definitely the case that almost all of us experience psychosis in some form or fashion throughout the course of our life. And when we look at that more severe end of the spectrum, we see that apologies, my labels are not showing up for some reason, about 4% of the population experience what we describe as attenuated psychosis. So these are symptoms of psychosis that merit clinical treatment, that are distressing to folks, that get in the way of things that they care about in life, but still don't meet full threshold criteria for receiving a diagnosis of a schizophrenia spectrum disorder, which about 1% to 3% of the population at some point in their life will receive. And when we look at folks who get these diagnoses of attenuated psychosis syndromes or are experiencing attenuated psychosis at this level, and we follow them for a couple of years, we see that about 30% of the population tends to develop a full threshold psychotic disorder. About 30% of folks still continue to experience these attenuated symptoms. They're not at that full threshold level, but they're still present and still causing some distress or impairment. And about 30% of people experience remission of their symptoms. So I think there are two things that are really notable when I think about this information, which is if you're someone who is experiencing attenuated psychosis, it's more likely than not that you will not go on to develop a full threshold psychotic diagnosis. So there's every reason to hope that prognosis and outcomes in the future will be positive for you if you get a diagnosis of something like an attenuated psychosis syndrome. That being said, it's also something that we as clinicians might perk up to see that people who have these attenuated psychosis symptoms, about 30% of them go on to develop a full threshold psychosis disorder. And that represents an elevated risk as compared to the 1 to 3% of the general population. So these folks, it might be people in particular who would benefit from monitoring, kind of touching base with early on when experiencing these symptoms, to keep an eye on how things might move forward. And there are a few different ways that we as clinicians and researchers distinguish between what is an attenuated symptom and what is a full threshold symptom. And there are 2 or 3 different things that are meaningful to us. One is the intensity, severity of these symptoms. So how frequent are they? How developed or formed are they? How distressing and impairing are they? Also, most importantly, the degree of conviction. So how much someone believes that these things are really happening, and how much kind of doubt or insight do they have into these being potentially things that could be reflective of mental health concerns rather than reality. So I'll give a few different examples of what an attenuated versus a full threshold symptom of psychosis might look like, starting with hallucinations, or one of those 2 types of positive symptoms. So someone experiencing that more attenuated kind of level of psychosis could say that they see indistinct shadows or flashing lights, and it's happening at least weekly or so, but doesn't seem to be particularly formed, and they think it might just be kind of a glitch or something kind of new in their vision. They don't think that something might be really happening. Whereas someone who is experiencing more full threshold types of symptoms might report seeing a fully formed person hovering outside the second floor house out of their window. So this, you can see, as compared to the other example I gave, is much more formed and much more intense of an experience. Thinking of these 2 different examples for delusions, one example could be a person going to a park and feeling like people are staring. So they might feel a little bit uncomfortable when going about activities in their daily life, whereas someone experiencing a full threshold symptom might refuse to go outside at all because they're very convinced that a neighbor is plotting to kill them. So you can see on the one hand, person experiencing attenuated psychosis might have these feelings pop up. It might feel uncomfortable or distressing, but it still doesn't really get in the way of doing things that they want to or need to do. Whereas someone with that full threshold psychosis, it's really impacting their day-to-day functioning, and the kind of rationale behind what's going on is much more developed. So who experiences psychosis? We know that for adolescents and young adults, this is often the period of time when we see the onset or first episodes of psychosis. So typically between the ages of 15 to 25 is when we see the first episode or the first kind of early symptoms of psychosis emerge. And these can kind of continue to develop over time into young adulthood. And when we think of the prevalence of early psychosis, about 100,000 adolescents and young adults in the United States each year will experience their first episode of psychosis, which, thinking to our home here in Maryland, translates to 2,000 young people in Maryland each year having a first episode of psychosis, or about 20 folks every week, I believe. So we often think of or talk about psychosis as a kind of low prevalence or more rare mental health disorder. But when we think about these many people experiencing their first episode of psychosis each year in Maryland, it really kind of brings home how many youth in our community might be struggling with these symptoms or needing help or support each year. And when we think of that kind of developmental trajectory or these kind of early time points in people's lives, we see that for people who go on to develop diagnosable psychotic disorders, there's a pretty typical or standard trend where in early childhood, we see early signs or symptoms of psychosis, but they're non-specific or things that are really difficult to use as predictors or kind of factors to drive early intervention, things like social difficulties, motor abnormalities, or cognitive deficits. And when we see that adolescent phase, we see the emergence of these attenuated symptoms, so clinically significant yet subthreshold symptoms of psychosis. And then around later adolescence to young adulthood is when diagnosable psychosis emerges. And thinking of that time point of adolescence and young adulthood, we note it's not only the time point when psychosis often emerges, but also when there are a lot of really important developmental tasks going on for our young folks. So this can be things like finishing up school or starting up school, whether it's college, high school, or training programs, thinking about their careers, building their professional identities, seeking and building relationships, whether with peers, romantic relationships, forging new kinds of stages of the relationships with caregivers and family, and also just building independence and identity. So this is a time when a lot of great stuff is going on that can really set the stage for life moving forward, but also a point when psychosis can really disrupt a lot of these critical and important things in folks' lives if there's not the right kinds of intervention or services to support young people. So that's why early identification intervention is so critical, and why we at the Maryland DIP are so passionate about this goal. So we know that there are a host of negative outcomes that can be associated with psychosis, and this is particularly true when we're not able to provide early intervention. That being said, it's, I think, important to take a kind of strengths-based recovery-oriented perspective and recognize that even for folks who have chronic illness, everyone is able to often kind of seek a full and successful life, or even to experience positive changes from psychosis, whether that means identifying personal strength through having this experience of illness, or having spiritual growth, connecting more closely with family or support networks. So we always like to say that diagnosis is not prognosis, and no matter where you're at in that spectrum of psychosis or kind of journey in your illness, there's always reason for hope. But we do know that in particular, the best outcomes tend to be associated with early intervention. And when we think about that, one of the key things that comes to mind of things that might be driving this relationship and things to think about with regards to intervention is something we call the duration of untreated psychosis, or DUP. So if we think of that trajectory again, and the marker of the first onset of psychosis, and then we think about the time point when someone first gets treatment, the time period in between those two things, when symptoms first emerge and then when folks get treatment for these symptoms, is what we refer to as the duration of untreated psychosis, or DUP. And unfortunately, on average in the United States, DUP is about 2 years. So that represents 2 years when these psychosis symptoms are really distressing, really impairing, getting in the way oftentimes of young folks' goals in their lives, but they're still not connected to treatment to help cope with these kinds of experiences. We know that shorter DUPs are associated with a host of improved outcomes, whether that's better functioning across different domains, decreases in negative experiences of symptoms, or better outcomes in the types of care that folks receive. And we also know that oftentimes without early intervention, things are less optimal, whether that means there are barriers to enter mental health care systems or discontinuity between care. Oftentimes there can be bad first experiences with treatment, whether that means coercive treatment, or whether that means having really negative experiences with medications because folks are in an inpatient setting and they get kind of given medications to stabilize really quickly that can lead to really negative side effects, or it can mean kind of miscommunication between providers and families, or oftentimes no communication at all, particularly for folks who are legally adults. So thinking of these kinds of problems that can occur and what might lead to lack of early intervention or longer DUP, it might be the case oftentimes that folks don't know what psychosis is, or that clients, families, or even healthcare providers don't know where to go for help. And the ways that we can tackle these things are through activities and interventions like the ones we're all together doing right now, outreach and education to all different kinds of folks in the community to know what psychosis is and where you can go to get support for these kinds of concerns. Another thing that is helpful to think about is that we might want to know where we're assessing for psychosis, or think about different kind of screening practices and procedures to make sure that we're catching folks who are experiencing these symptoms early on, so that we're able to get them connected to care. And that's what we at the Maryland EIP do. There are a lot of different components to the work that we do that really kind of tackle all of the different kinds of elements of early intervention that I described earlier. So we have our outreach and education component, which provides different kinds of information to all different kinds of folks in the community about what psychosis is, what resources might be available to people in the Maryland community, and how to connect with us. We provide consultation and evaluation services. So these are things like kind of connecting to a clinician if you have some questions or want to know more, or even getting a thorough evaluation. We provide treatment services to people experiencing both attenuated and first episode psychosis. And also we provide technical assistance to psychosis provider teams across the state of Maryland to help implement best practices for working with young folks experiencing psychosis. So when in doubt, please reach out. You can get connected to us by phone. We're available by email. We have a website. There's so many great resources that I do not have time to do justice to, but please connect with us more if you'd like to hear more about what we offer. So now I'd like to focus, and I apologize, I'm going over my time, so I will go quickly through some of these things. But I think it's always very important to think about ways in which we can better serve our underserved and marginalized populations in the community. These are folks that often are at elevated risk for negative outcomes in early psychosis. And there are a lot of different kind of practices or procedures that we can implement to make sure we're giving the best, most culturally sensitive care. So I have a whole slide here on the history of psychosis, but what I think is important to reflect thinking about this is that oftentimes what's going on in historical context at the time can really influence the way we understand or conceptualize concepts like mental health concerns or psychosis. And this is true for psychotic spectrum disorders as well. So in the early 20s and kind of up to the 1950s, psychosis was kind of conceptualized as a disorder experienced by white folks. It was described as kind of difficulty coping with the world. It was thought to be experienced by people like poets, academics, kind of eccentric or unusual folks and women. And as we saw in the emergence of the civil rights movement in the United States, we also saw a shift both in the demographics of individuals being diagnosed with psychosis to an increasing number of Black individuals being diagnosed with psychosis, and also a shift in the way that we understood this kind of mental health concern from something that was kind of unusual or eccentric or maybe out of touch with reality to something increasingly understood as kind of more aggressive, violent, or paranoid and suspicious. And we can even see this reflected in some of the cultural content at the time. So I'm showing here two different ads in psychiatric journals for antipsychotic medications. And you can see in the 1950s, the individuals shown and the words used to describe psychosis and the treatment for this concern look very different from the ads we see on the right there from the 1970s. Both words like assaultive and belligerent being used in that lower ad to even some kind of dog whistles in the ads up top there showing African artifacts in conjunction with antipsychotic medication. And I bring this up to share that oftentimes we sometimes think about mental health treatment or kind of the research or ideas that underlie our understandings of mental health as objective and scientific, but it's undoubtedly the case that all of the content in these kinds of domains are really infused with biases and kind of the context of the time in which we develop these ideas. And these are even influencing the way we think about psychosis today and the way that communities might experience receiving a diagnosis of a psychotic disorder. So I think very important to be mindful of the historical context. And when we look at the outcomes of psychosis from entry into care all the way through the outcomes in care, we see that there are significant disparities experienced by minoritized or underserved youth and families. This is particularly true for folks from minoritized race groups, particularly African Americans, but all different kinds of underserved communities and different kind of intersectional identity factors that can play a role in disparities in care. And I unfortunately don't have too much time to go through everything, but I'll briefly review different factors that can drive disparities. Firstly, things can occur at the individual or interpersonal level. So these are things like individual biases or stereotypes that might influence someone's care. We do know that there is a great deal of bias that can influence the assessment of psychosis. There's a number of studies showing disproportionate rates of schizophrenia spectrum diagnoses among Black individuals compared to their white peers. And in a particularly interesting study that looked at diagnosis or re-diagnosis rates in ethnically diverse groups, what folks did was they did a medical records review and found that if they use culturally sensitive tools, they were seeing how rates of re-diagnosis might change. And for non-schizophrenia spectrum disorders, there was a pretty low rate of re-diagnosis. However, there was a really high proportion of individuals that were originally diagnosed with a schizophrenia spectrum disorder that were re-diagnosed to something, particularly PTSD or adjustment disorders. So we know that when we are seeing folks from diverse communities, there is a high likelihood of misinterpreting symptoms as psychosis when in fact something else might be going on, whether it's trauma or mood disorders or the like. We also know that beyond misunderstanding or kind of misinterpreting mental health symptoms, there's also a propensity in our field to overpathologize normative experiences. And we know that perceptual abnormalities or different kinds of hallucinatory experiences can be culturally bound. And one particularly interesting study looked at the rates of schizophrenia spectrum diagnoses related to auditory and visual hallucinations. And what the study found, looking in a sample of African American individuals, is that when folks endorsed these kinds of hallucinations overall, these endorsements were strongly linked to a schizophrenia spectrum diagnosis. But when the researchers kind of selected only spiritually related content endorsed in auditory or visual hallucinations alone, this was not at all linked to schizophrenia spectrum diagnoses. So when we're implementing culturally sensitive assessment, this might not be a problem, but we know oftentimes that's not the case in care. So sometimes folks might endorse these kinds of spiritual, auditory, or hallucination types of experiences, but it's not truly linked to pathology alone. So something important to be mindful of. Moving along, there are also institutional or organizational factors that can be responsible for disparities in care. Oftentimes these can be things like the practices around how different care providers deal with racism. One kind of interesting broad meta-analysis and review study found that racially minoritized group individuals often endorsed either experiencing inadequate healthcare related to experiences of racism or feeling dismissed in healthcare interactions. And these types of experiences were linked to both a lack of trust in care providers and delays in seeking healthcare. And despite this being true, a lot of staff in treatment settings reported that they kind of conceptualized or considered healthcare to be impartial. And often there are no organizational practices in place to discuss or address racism. So there are not only individual biases that play a role in disparities in care, but also the ways in which our organizations set up policies and practices. And lastly, and most importantly, structural or systemic factors or things that represent an interplay of policies, practices, and programs across institutions can play a strong role in disparities in care. One study in particular that highlights this is that as the neighborhood ethnic owned group density decreases for folks, so the less that there are people who look like them or come from the same cultural groups as them, when that lowers, it's associated with an increase in risk for psychosis. So beyond these kind of individual or institutional organizational practices, kind of broader systemic or structural oppression or discrimination seems to be linked to an increase in risk for psychosis, in addition to negative outcomes as well. So this is why it's critically important as a field for us to be thinking about and implementing culturally sensitive care. I'm going to skip through because I'm seeing how over time I am, but One thing that is important to consider is that we really need to kind of go through a mindset shift. And if we think about ways that we can implement individual practices, or we can implement culturally sensitive care only with the clients that come into our programs, or can be in the room with us, then we're missing out on addressing really important disparities in care. And we're missing out on thinking of how we can work to connect with and provide treatment for folks who aren't even showing up into the clinic. So a lot of times these structurally or systemically based problems require structural or systemic solutions from us as individual providers, as organizations, and as individuals kind of collectively as well. So that means one thing we can do is to broaden our definition of who our clients are, from people who come into our clinics or programs to the broader community writ large. So one of the ways that this can manifest for us is to really broaden and focus on our outreach efforts to try to reach individuals, clients, communities, different kinds of advocacy groups that aren't maybe being served in equal ways, or that are maybe experiencing less access to care or different types of care opportunities. And one example of the ways in which our team in the Maryland EAP are doing this, and one opportunity that I wanted to share with you all, if you're interested in this topic and getting a deeper dive, we at the Maryland EAP are collaborating with some really spectacular collaborators at the Morgan State University School of Social Work to review our different outreach and education practices, and to develop trainings that are culturally sensitive and particularly focused on providing services and care in early psychosis to African American youth and folks from urban communities. So this is a way in which we've partnered to kind of identify what are our practices and procedures, how are they fitting the needs of a different community that we are attempting to serve well, and also thinking about how we can connect with providers in that community to provide trainings. I also just wanted to say that we recently just completed our first training, but I believe we are very much hoping to do more of these. So please feel free to email us at the email address I showed earlier if you're interested in thinking about doing this training. We'd love to have folks, and we'd love to continue to do these trainings. Another thing that is helpful, thinking about that kind of broader mindset shift, is to think about and consider how you might need to implement more time, more organizational or institutional support or infrastructure needed to provide more intensive efforts and services to connect with clients and families from underserved communities. So this might mean making more time and space for culturally sensitive supervision, creating more time for outreach and connection efforts, spending more time in your sessions with these clients, just kind of making sure that you're thinking about the kind of policies and procedures in your organization and ways in which you can kind of build more time to support the efforts that are needed.
Pamela, can I interrupt for just a minute? Because you have a very related, on-point question in the chat.
Oh, wonderful. Thank you.
So I just wanted to mention, so our colleague from our Brain Trust here, Valerie Davis, put in the chat, the facts you present are traumatizing in themselves. How do you suggest that we as Black family and community members deal with the trauma of racism and slow systemic change while hearing ourselves and others? So I think really great, important question.
Yeah, I mean, that's a wonderful point. And it makes me think of a few different things, although I defer to my wonderful colleagues here presenting as well for their thoughts. One thing that comes to mind for me is that it's important a lot of times when we think about these disparities in care, not to put the onus on Black youth and families for solving this problem. I think that that's something that is oftentimes the case in the research that we do, the work that we do, and the interventions that we think about. How can we, empower clients and families to address these disparities? But it's, the case that it's either oftentimes these institutional or organizational practices, or particularly, the systems and structures that are responsible for these inequities. So I think we need to be really thoughtful as a mental health care provider field to think, how are we contributing to these outcomes, and how can we take it upon ourselves to implement changes? And the other thing I think that is important to be mindful of is not just focusing on kind of the negative side of things, the disparities in outcomes, the ways in which we often fall short of providing mental health care to Black youth and families, but also just to take a strengths-based approach and think about what are the ways in which Black youth and families are thriving, what are their kind of natural areas of excellence that we can leverage to be able to address, these concerns. I think as I'm saying that, I'm reflecting that can sometimes be a double-edged sword, and I think we can use resilience sometimes as a way to get out of the responsibility of making important changes. So we don't want to, certainly use strengths or resilience-based approach to kind of get out of doing the work that we need to do as a mental health care field. But I think it is often important when we think about working with Black youth and families, not just to focus on all the problems or things that aren't going well, but to really highlight the myriad of strengths that are present in these young folks and in their families' lives, and kind of the connection there too. I'm going to pause because I have a bunch of experts here with me presenting as well. If you have any other thoughts or ideas, I wanted to make space for that.
Yeah, thank you for sharing your reflections, Pamela. I agree with all of those. And thank you, Valerie, for lifting up that really important question and just acknowledging the fact that the reality of racism is traumatizing for Black children, families, and the whole community. And as far as kind of like, what do we do? I think about, as Pamela mentioned, the responsibility for institutions, including our health and mental health care institution and system. And also, Valerie, in your second part, you lifted up some issues with COVID and unemployment. So our social services, our criminal legal system, our school systems, there's a responsibility on the part of our systems and those in power within systems to be really honest about how racism is perpetuated in our systems and move toward anti-racist practices and policies that address racism and perpetuate racial equity. And related to the question of what do we do as the community, as Black people or and Indigenous people and other people of color, what do we do even in the face of these structural barriers, include racism, classism, sexism, all of the isms? What do? We take care of ourselves. And I love this comment around like really utilizing a strengths-based approach to the way that we think about ourselves, and know that despite racism and other forms of oppression, that we are surviving, and many of us are thriving, and that there are pre-existing strengths and assets inherent in our communities. And there are things that we do well and thrive even in the face of oppression. So we continue to call out racism as a traumatizing system, and we continue to do the things that we have been doing in order to thrive and be well. It's kind of like doing, it's a both and, not an either or. So I love that you raised that question. I am sending compassion to you and everyone else who are sitting with the reality of how traumatizing racism is. And I appreciate you all joining us today and sharing those types of reflections. It's important that we don't hold back on those types of reflection.
Thank you so much for that. And as you were speaking, it brought to mind two other things that I wanted just to briefly highlight, which is I think it's really critical that thinking of those organizational practices and changes, that we make really concerted efforts for our clinical workforce population, for folks in research, for folks who are responsible for setting the course of mental health, that those individuals reflect the communities that they serve. So when there are underrepresented individuals in the workforce, creating pipelines or being intentional about different kinds of organizational practices, not only to recruit people from different communities, but also to support their experiences in both mental health care, academia, research, so that we have the most robust and diverse workforce, so that clients can feel comfortable or feel seen in care. And the other thing that I think is helpful to share is that oftentimes when we think about culturally sensitive practices as clinicians and providers, we feel very concerned about the likelihood that we have, because of our own biases, to overpathologize or misidentify different kinds of experiences as psychosis. And that can lead us to kind of feel so nervous about making mistakes that we hesitate to ever kind of look further or to think about what, for example, Black youth might be experiencing. And in that ways, we might be perpetuating inequities by not being able to provide early intervention care for all individuals. And it's only those folks that, we're able, or we feel comfortable asking these questions or feeling like we are able to kind of tease apart what is cultural and what is possibly a mental health concern. That also leads to further inequity. So I think as clinicians, it's really important for us to put ourselves into that uncomfortable space, and also to make sure that we're learning the skills to provide good and culturally sensitive care, and to not commit kind of microaggressions or even just explicit racial aggressions in services, so that we only are giving care to one group of individuals. We have to make that balance and push ourselves to be uncomfortable so that we're being equitable in the types of services that we provide. I apologize that I can't see the chat, but please, to my co-presenters, feel free to jump in if there's anything. I'm sure that all the questions are wonderful, but anything particularly pertinent to what I'm sharing.
I'll read out some of the reflections that Valerie Davis is lifting up in the chat. Noticing that we have to be explicit in sharing power by shifting seats at the table and valuing lived experience as valuable and expert. And Valerie also commented that philanthropy is one of the most gender and race segregated spaces with cover by being nonprofit and service oriented.
Absolutely.
Yeah, this is JB Moore. I want to just jump in here and just thank each of our panelists for such a great presentation. We're down to about 12 minutes, so we would like to encourage you to put your questions in the Q&A section. We also have pulled a couple from there. We have one for you. Someone wants to know, how can we see the PowerPoint slides with all the labels? Can updated slides with the labels be uploaded somewhere to view in its entirety later?
That is a great question. My apologies to everyone. I was trying to be fancy with my nice Canva labels, but technology is always foiling me. So I would be thrilled to fix that, and I will connect with the wonderful tech folks and be able to share a copy of these slides. And I'll just try to quickly go through. I have just a few more minutes of things to share, and then some space for Q&A. We seem to have an extremely wonderful and interactive audience, so I would love to hear your questions and have more discussion. So I will continue to move through real quickly. As I think we've kind of thought about and discussed earlier, taking an intersectional approach to understanding the interaction between folks' different identities, context, systems, and implications of stigma is important. So thinking through, what does it mean for this client that I'm sitting with to receive a diagnosis of psychosis? How might other people interpret this? How should I be thoughtful in sharing this information, writing it in medical records, and kind of thinking through all the myriad of ways in which this can not only impact the experience of folks in the room, but also can impact their experience of care or other things later on. Culturally sensitive assessment is extremely vital, as I alluded to earlier. This means asking clients and families how they understand their own culture, context, identity, being mindful and even explicit about different kinds of client and family provider interactions, if there are experiences of racism that might be impacting what's going on in the room, being able to create a space to name that and discuss. Understanding how clients define and understand their problems or concerns, what they think might be causing it, both what's going on internally and externally, being able to perform inequity assessments or understanding not just with mental health symptoms, but kind of writ large what's going on with folks that might be contributing to their experience of mental health and wellness, and also their experience to be able to engage in the things that they care about, and really addressing those as clinicians or providers. And again, taking that holistic perspective, not just thinking about the concerns or problems that folks are experiencing, but really what are the myriad of strengths and areas of resilience and things that they're just doing spectacularly in. One of the tools that I strongly recommend to folks always to use is the cultural formulation interview. It's a really great kind of structured way of getting at these things. It's very easy to use, and also creates a lot of space for clients to share their own perspectives. It can be really helpful to disrupt organizational practices. So for example, the ways in which we might be biased in our communication, both through kind of providing or requiring clinicians to address their communication practices. And these kinds of interventions are seen to be very useful, but also using interventions that are shown to help activate or empower clients in these healthcare settings as well, to know how to navigate these systems. So that is what I have to share. I'm so grateful for such a wonderful audience. And again, this is only the very beginning and the surface of this area. So I strongly recommend you reach out or connect with the resources that I alluded to earlier. And I'm really looking forward to hearing your questions, thoughts, ideas, and to discuss more.
Well, we have a couple of questions here. I have, does Maryland EIP have resources like a toolkit, for example, for messaging to youth and young adults, particularly in marginalized communities?
That is a great question. I wish we had just a link that I could share you with toolkits. We don't have that yet, although I think we're in the works developing materials like that. But we do have a number of resources available more broadly. If you connect with us through the email in particular, and you're also welcome to email me as well. We have different kinds of flyers, resources, but in particular, we can provide consultation, outreach and education, and other kinds of training and support services to think about and kind of brainstorm what you as clinicians or community members might be experiencing, what your kind of unique or particular needs are, and how we can kind of work together to create those resources or think through how best to educate folks about psychosis.
Another question here. Can you share what psychotropic drugs are most effective in diffusing psychosis?
That is one that I will potentially defer to the expert on this panel here, Dr. Reeves.
Yeah, so thank you so much for the question. So there are medications called antipsychotic medicines that are helpful for targeting psychotic symptoms. And the good thing to know about antipsychotic medicines is there's a lot of options. And there's options both in terms of what drugs people take as well as how they take them. So it's nice always in life to have flexibility and to think about what's the best fit with what your needs are. So these medicines are available taking like you would a regular prescription medicine as a pill, a tablet, a pill, a liquid. So they're taken orally. For some people, they prefer having a medicine that they in a form that they can take it less frequently. They don't want the hassle of taking it every day. And so there's medications that can be taken by injection form where you don't have to get the medicine, receive the medicine quite so frequently. It may be every few weeks or every month. And now there's even newer medicines that last for even a few months. So there's flexibility and options in terms of how to take it. And then there are a lot of different specific drugs within that class. And so as a prescriber, usually we think about things like the age of the patient. So Pamela mentioned that these conditions can affect teenagers as well as young adults. So some drugs have been studied more in younger people. And so we have information on both the safety of those medicines and how well they work in younger people. So if it's a teenager, we'll try to go with those sets of different options. And then we try to understand what are the biggest concerns somebody has about side effects and what type of medicine would be the best fit for them. So so if you want more specific nitty-gritty about like names of drugs and things like that, I'll put my email in the chat and I'm happy to follow up with you. But please know the big take-home message is there's a lot of choices, both in terms of the type of drug delivery system or how to get the medicine, and then as well as different options based on kind of what we know works well for certain patients, as well as safety concerns.
Thank you. Thank you for that. We have another question. How do you advise schools to quickly and rightly ramp up to have this knowledge and properly apply it, especially in light of the systematic racism, well established, documented, and escalating in school systems?
Yeah, that is a great question. A lot of times we as an early intervention collaborative love to partner with schools because there where a lot of young folks are. But I think it's important to consider, I think it's the person who wrote this wonderful question described, what are the ways in which we can do early intervention without stigmatizing, over pathologizing, or perpetuating inequities. I think there's a few different ways we can do that. One is just to kind of connect more around training and education, and best practices, and how to understand psychosis, and understand what psychosis looks like in diverse populations. So if folks are interested in this, if this resonates with them, and they're in a school that this sounds like a great thing that they would like to get connected to, you can always reach out to the Maryland EIP. We're happy to provide either an initial training or multiple trainings on how to do this. Another thing I think is important is to take kind of a stepped care approach to screening, and to kind of approach it as I describe as a curious scientist. So first start by just figuring out what's going on, using these tools to assess whether there are symptoms, but then follow up by saying, like, what does this mean for you when students endorse these kinds of experience? What do you make of that? Is it getting in the way of stuff? Is it something that's upsetting to you? A lot of times folks say yes to different items in our psychosis screening tools, but it's something that's normal for them or accepted within their community. So not only implementing these kinds of screening tools and approaches, but also getting a sense of what's going on from the students as well, and using screening as not just a method to identify someone and pass them along to a care setting, but also just for starting that conversation. I'm mindful, though, as I'm talking, that I have an expert in working in school settings. So I'm happy to hear if you have anything to add to that, which I'm sure that you have a lot of wonderful insights.
Yeah, those are awesome reflections, Pamela. And I just wanted to highlight some of the resources that I'm sharing in the chat box related to that question and other questions here. So a resource related to healing from racial trauma from augsburg.edu. And I encourage folks tuning in to look into the work of Dr. Sean Jenright, who talks about healing-centered engagement and how we can move away from pathologizing communities, rather focusing on the pathology within systems that are oppressive, and also support ourselves as well as the young people and families we serve in healing. And then I've also included resources related to promoting equity and anti-racism in schools. Schoolmentalhealth.org has a list of resources for schools and educators on how to promote diversity, equity, and inclusion and anti-racism in schools. And one of the resources that I was a co-developer on is called CIE-WISE, which stands for Cultural Inclusiveness and Equity, Wellbeing Information and Strategies for Educators, that provides, it's a free online course for educators on how they can promote cultural inclusiveness and equity in schools. So please check out those resources.
We have time for one more question, and I have it here. Someone would like to know whether the antipsychotic drugs mentioned earlier, routinely tested within minority community groups and at a representative level.
Yeah, that's a great question. Thank you. So with medications, there's quite a lot of testing that happens through the FDA before drugs are available and on the market. So they do some basic safety testing in a healthy population of adults, and then they do some studies in folks with mental health diagnoses and do testing. And it is an important issue to expand the diversity of individuals who participate in these studies, because these studies are the things that base what we do in clinical care. And so that's been a point of contention by the federal government. And one of the things that they monitor very closely now is if you apply for research studies, you have to project before you even start the study what your plan is for enrolling individuals and the diversity of the individuals that you're going to enroll. And then they track that over the course of the study. So there are some structural things in place trying to help with improving that, but there's a lot more that needs to be done.
Again, we're so grateful for each of you panelists. And if you didn't get a chance to ask your question, you can send your question to connection@namimd.org. Thank you, everyone, for your participation today, and take care.
Thanks, everyone.
Thank you.